Great. First of all, for those who don't know me, I am Jonathan White. I'm English, but I'm very proud to have become a Belgian citizen 6 months ago. So, thanks. I should be thanking you, really, not the other way round, as I am a Brexit refugee. So I work at Erasmus Hospital mainly, and academically ULB, and also at UMans. I lecture at UMans. And I also work for the WHO, and I've just got back from Geneva. So if any of you are interested in global health or the WHO and would be interested in being involved in projects, then feel free to contact me. My email is included at the end of the presentation. I'm really glad that there are so many people here today and that you're all very motivated and taking notes and everything else. Just to say, my talk and all of the talks, in fact, will be sent to you in a PDF form. So don't worry about scribbling everything down, and you'll be getting some questions to practice as well. So I'm very glad you're here. I have a vested interest in educating you because you are going to be looking after me in 20 years' time when I have my BCC and my senile pruritus. So I'm counting on you to take care of me, okay? But today we're going to talk about phototoxicity and photoallergy. So this is you might very well see a patient like this who comes in to see you, and you have to think, what's going on? What could it be? The problem is that the differential diagnosis is very wide, as we heard in the previous lecture on photodermatoses. So there could be many possible reasons why the patient has developed this rash. And hopefully, at the end of the session today, you'll have a bit more of an understanding about phototoxic and photoallergic reactions and how, in many cases, we can distinguish these by clinical means, by the history and examination. And, of course, sometimes we need to do tests as well. So, first of all, we're going to talk about phototoxicity. We're going to talk about photoallergy. And we're going to talk about how to test for photoallergy, because we need to do it well. You need to make sure wherever you're working that we're doing it in a robust and safe way, and that we get good results, and also that you can interpret them. So we're going to go through some scenarios, 2 simple scenarios, just to give you an idea of how you can interpret photo patch test results. We're going to talk about some learning points at the end as well. So let's start with phototoxicity. This is by far the most common reaction, much more common than photoallergy. I've taken a broad definition from ICD-11, and if you haven't already looked at the website for ICD-11, you need to look at it. So I've taken it as a definition of a non-allergic form of skin inflammation caused by the interaction of UV or visible light and a photoactive substance. So you see the definition, you've excluded allergy. You don't always need to do testing for that, but sometimes it is important in overlap cases. So usually you have cellular damage and it's oxygen reactive species, as we've just heard in the talk from Alex Anstey, that's relevant for the damage in porphyria. So similar species are responsible for phototoxic reactions. You can have exposure to these substances which cause phototoxicity either through topical exposure or by systemic exposure. So there are many substances that have been reported, and I'm just going to mention a few to illustrate the point, but there are many, many thousands, more than thousands of chemicals that can do this. So in terms of topical agents, let's not forget the plant substances, and particularly as we are into warmer weather, people are maybe out gardening, they're out doing sport in parks and forests and things, and there's a lot of exposure to plant substances, either directly contact with the skin or, of course, airborne exposure as well. And there are various different plant substances, fragrance chemicals, and furocoumarins, which may cause this phytophotodermatitis, which is a very typical reaction with blistering after exposure to plant substance and ultraviolet light. We have tar, which may be relevant for work exposure, but let's not forget the fragrance chemicals, which exist in nature, but also if you get the metro number 5, people are spraying deodorants all through the journey when I'm going to work. So it's really quite annoying, for particularly people who are allergic, but of course you can get a phototoxic reaction to these things, and of course they can be photoallergens as well. Citrus oils are important, widely used. People like essential oils. You know, it's natural, doctor, it can't cause a problem, can it? Well, it can cause a problem, and I'll tell you about a case I saw in London some years ago. And also the cosmetic ingredients which are applied topically in terms of makeup, in terms of sunblocks, and other things that are applied to the skin, such as moisturizers even. There are many, many other topical agents. I've just listed a few to give you an idea. So I put some examples in here. So parsley, for instance, is a common cause of phototoxicity with skin contact. In ancient Egypt, it is said, and I don't know whether Professor Lambert will talk about this when he's talking about phototherapy, but it is said that the ancient Egyptians rubbed the reeds that grew in the Nile Delta on their skin to plaques of psoriasis and sat out in the sun for their heliotherapy. And this is a primitive form of phototherapy, really. But of course, that's when it's using to treat something, but it can cause the disease as well. Giant hogweed is a very important cause of phytophotodermatitis and many other plants and weeds that we will be in touch with in nature. I've put the photo of the oranges and, of the lemons and the limes here because I had a patient who came to see me in London with a terrible phototoxic reaction, and the problem is he had the high penetrance gene for melanoma as well. That's why I was seeing him for a checkup, and he'd lost 2 of his relatives at the age of about 45 who died of melanoma, and he came to see me with this terrible phototoxic reaction, and I said, what on earth has happened? And basically he'd had a sauna, so he'd taken off a lot of his stratum corneum. He then had a massage with with lemon peel and essential oils, and then he'd driven 2 hours to see a friend in a convertible car in the summer with the top down and not wearing any sunblock or anything. And he had the most terrible photo burn, basically, but it was the citrus peel that was the problem here as well. So just to say, you have to take a good history and ask what's been going on. In terms of the systemic agents, there are many things, and I'm only going to illustrate a few targeted ones, but the list is very extensive. And if you're not sure about a medication, then really you should look it up, because you can't know all of the potentially photosensitizing medications. Obviously, we use a lot of tetracycline-based antibiotics in dermatology. Whether that's a good thing or not is another story, but we do use a lot of it. Antifungals as well, azoles and griseofulvin. Non-steroidals, obviously, they can be used topically as well, and they can give you phototoxicity, but obviously systemic use as well. People often forget to tell you they've taken them because they've forgotten they had a headache in the morning for which they've taken the tablet. Many cardiac medications, statins, very commonly used, diuretics, diltiazem, and even the medication that was designed in Belgium, amiodarone, which is a very good non-proarrhythmogenic treatment for arrhythmias. And there are many other things, including retinoids we may prescribe for our patients, acitretin, isotretinoin, etc., anti-diabetic medications, but also some plant-based treatments. So people, again, forget to tell you that they are taking herbal supplements. They think it's not going to be relevant, but it may be very important in your history. So don't forget to ask about these specifically, and particularly herbal supplements. Of course, this is important. I'm sure that Professor Lambert will say this. Before you do the phototherapy, we don't want to cause any harm. You need to be asking about these medications before you start that. And again, do look the medication up if you're not sure. So what are the clinical features? Well, sometimes we utilize phototoxic or phototoxic-like reactions for therapeutic purposes, so it's not always a bad thing. But the reaction that patients will get, it's like a sunburn, but it's usually much more pronounced. For the same amount of, without the phototoxic agent, they would never have got such a bad sunburn, or it's maybe minimal contact on a day where it's not so hot and the UV index is not so high. It's not usually eczematous. Clue, this might be important for the questions you're going to get at the end. So it's not usually eczematous. So unlike photoallergic contact dermatitis, where you often see an eczematous change, if it's chronic exposure, you might see lichenification, but you don't normally see that. Phototoxic reactions can be slightly itchy when the skin is peeling afterwards, but it's not usually very itchy like it would be with a photoallergy. Also, the history will give you some clues. It usually occurs within minutes to perhaps a few hours after exposure. So it's a bit quick for a sunburn, perhaps, and obviously photoallergy sometimes can take a lot longer to show. There is usual sparing of the skin folds, and this can be helpful, and usually resolves with peeling and sometimes dyspigmentation, which is variable depending on the photoskin type. The diagnosis is usually clinical, but we sometimes need to do phototesting because we need to exclude or phototest or photopatch tests in case you're thinking of something else. So, of course, in teaching scenarios, you are given the classical presentation and it's very easy. In real life, it's sometimes quite difficult, and sometimes we're not even seeing the rash. We see photos which are not very clear, and you're trying to work your way back. The patient doesn't remember exactly what was happening. So sometimes we need to do tests, and there is a legitimate differential diagnosis to explore. So let's go back to this patient. This is a phototoxic reaction here. We see the sparing where he's not been sun exposed. And here another patient with a phototoxic reaction, and we see in her sort of age-related or sun-related wrinkling that she's not getting the reaction. Now, in terms of medications that cause photosensitivity, there is some emerging evidence that this will increase risk of skin cancer. So things like diuretics and whatever that cause photosensitivity may increase your risk of getting a skin cancer. And of course, it's important in terms of management for them to avoid the relevant products, or sometimes you can substitute the medication for the statin for something else that's not going to be phototoxic. Of course, I'm not going to go into this as it's been dealt with already, but appropriate topical sunscreens and protective clothing accordingly. So it's really giving good advice to the patient, and often they may work it out, but sometimes not. Let's move on to photoallergy, which of course is a more specific reaction, and this is a lymphocyte-driven process where there are clones of lymphocytes that recognize the allergen involved. It's obviously an immunological reaction. It's type 4 delayed hypersensitivity. But here, rather than an ordinary allergic contact dermatitis where any exposure with or without light is going to cause a problem, here you need to have an interaction of light with the chemical. And essentially, the chemical is not an allergen until it is modified by light. So it stands to reason that all of these chemicals have to interact with light, and some chemicals don't, of course. So there's no reaction if, let's imagine, they put the product on their skin and it's covered with clothing, then they're not going to get a reaction generally. The interval between the exposure and the rash is 2 to 48 hours. It's usually at least a day, to be honest, but of course when you have memory T cells in the skin, that might accelerate the clinical appearance. So what clinical features do we see? Well, of course, it's usually eczematous, so you get all the hallmarks of an eczema, so you're getting redness, you're getting itch, and you're getting perhaps lichenification if it's chronic exposure. You can have acute, subacute, or chronic presentations, obviously. And sometimes in very severe, extreme cases, and you don't see this very often, but they can be bullous. And sometimes you have almost subclinical eruptions where you just get a little bit of erythema, or sometimes not very much at all, and you just see the after effect. So you see a dyspigmentation, for instance, afterwards. Those are quite rare, but they can be seen. and people don't necessarily think about them. And unlike the phototoxic reactions, then these reactions may and commonly spread to non-photoexposed sites. So you can get spreading, particularly if it's a severe reaction. So that can help you distinguish between the two. What about the differential diagnosis? Well, you have to put phototoxic reaction in there. You have to think about an ordinary allergic contact dermatitis, not a photoallergic contact dermatitis. You have to think about another photodermatosis, and we've already had the lecture dealing with the most common photodermatoses. And then we also have a dermatosis with a distribution in photoexposed areas. Some people have atopic eczema that is just maybe photoaggravated, for instance, or a psoriasis, which is photoaggravated on the face. So it may be nothing to do with the products that they're putting on the skin or the tablets that they're taking. Seborrheic dermatitis will be very common as well. So actually, it's surprising to know that actually the prevalence is probably very small, actually, although probably there's a lot that's not diagnosed. So as dermatologists, we probably see the tip of the iceberg of people with photoallergic contact dermatitis. The predisposing factors are an underlying photodermatosis, but there's probably publication bias here. So these patients are going to be watched and studied, and they're going to go to fantastic units like UZ Leuven, and they're going to be investigated, and they're going to be thinking about this, and they're all going to get tested, and then you know. So there's some sort of bias in these patients because they're more closely watched, really. There may be some genetic factors as well, and we know that for certain types of allergic contact dermatitis, for instance to paraphenylene diamine, the hair dye chemical, or to nickel, that certain genetic predispositions make people more likely, and it's to do with the metabolism of the allergen and various other immunological factors. If you go through the literature on this, be careful, because a lot of the old studies have very loose definitions. They were not testing the people. It was all just on the history or things like that. And there's a lot of diagnostic difficulty. So I think you don't overinterpret the older studies because maybe they're not so rigorous now. Okay, in terms of the photoallergens, what are these substances we need to watch out for? Well, they're chemicals that can be modified by light. So actually, it's not surprising that many of them are sunscreen ingredients. Clearly, we have sunscreen ingredients because they're going to absorb light to protect our DNA from damage. So they're going to be photoactive. They're going to be changed by sunlight. They absorb the sunlight. So many of them, or most of the photoallergens we see, are actually chemicals that are used in sunblocks. And we are telling all of our patients for skin cancer checkup and so forth, be careful, wear sunblock, and all the rest of it. So we just need to be a little bit aware, although the risk is going to be rare, but that they could get a reaction or a rash with these chemicals. There's been a huge increase in the use of sunblocks, obviously, over the last 20 years. Don't forget, we're telling people sunblocks, and maybe this is why the Great Barrier Reef is having problems in Australia, because lots of these chemicals are leaching into the environment and causing environmental damage. But don't forget all these anti-aging products, many of them contain sunscreens. And of course, these sunscreens are also used to stabilize or as a preservative chemical for cosmetic items. So even though they don't list an SPF, for instance, or they don't say there's a sunblock in it, they're using sunblock chemicals as preservatives in makeup, foundation, or shampoos and various other things. So there can be unexpected exposure to sunblock chemicals. Don't worry about the list of the names, okay? So it's a bit complicated, but various different things absorb different types of light, and some of them are very old-fashioned, like the PABA chemicals. I don't really see them much used anymore. I don't know if my colleagues agree, but you just don't see them. So things come in out of fashion, some things go out of fashion for sunscreen ingredients. So physical agents theoretically do not cause, or let's say non-organic agents in sunscreens do not theoretically cause sensitization. So zinc oxide, titanium dioxide, microfine titanium dioxide, and then of course other ingredients of tinted sunscreens, which are becoming very important because we know that visible light can affect people for pigmentation problems and for cancer potentially. So those don't tend to cause problems, generally speaking. I'm going to take you through just a few studies very briefly. So this was a really large study. It was from quite a long time ago, about 20 years ago, but nearly 3,000 patients who were photo patch tested. Obviously, this is a biased group because you're suspecting that there's a problem here, but 2.3% had photoallergy. 65% of those were to sunscreen ingredients, so showing that it's a very common problem. And at the time, this was benzophenone 3 and 10, although probably that would be different if we were to do the same study now. But 2% of people had an ordinary allergic contact dermatitis to those other ingredients. So, allergic contact dermatitis is important as well. It's not all photoallergy in this scenario. And here is a list of the things. Just to say, the point of putting this on is that it's very important to do the photo patch testing with the sunscreen that they have a problem with, or you suspect a problem as well, because you can have a compound allergy when you test the individual ingredients, both conventional testing and photo patch testing. They may not show up, but it's the whole thing, because of course there are interactions between the chemicals in any product, so it can get a bit complicated, and the way around that is to test to the sunscreen itself as is, 100%. And this is another slide to show that most people only reacted to one agent on with photoallergy, although there are some people who are allergic to many things. And of course, being allergic to one thing is going to increase the chance of becoming allergic to other things, because you're going to reduce the threshold for sensitization and also for irritation reactions. So it's all kind of feeding into each other. There was another study about 10 years later, which was also a lot of people, 1,000 people, and there were lots of reactions. So some people had more than one reaction, hence the discrepancy in the numbers there. And they found that ketoprofen and etofenamate were the most frequent ones, and ketoprofen being used topically. But of course, you can have a lot of cross-reactivity. And again, sunscreens were a very important cause of photoallergy. So same study, the most common ones were octocrylene, benzophenone 3 again, that showed up in the previous one, and then some ones with extremely long names, which you need pretty much a degree in chemistry to kind of remember. And they highlighted the cross-reactivity between ketoprofen, octocrylene, and benzophenone 3, which is important because then they may be getting reactions with different products, so they think, it's not the product, it's maybe the sunshine itself. But you need to have a degree of suspicion for that. Don't bother listening about this. There are older ones, there are newer ones, but this is the European Photo Patch Baseline Series that was proposed by Carr et al. From that study, and this is what many centres are using throughout Europe now and elsewhere. We have another, so same paper, but topical non-steroidals are in there as well, obviously ketoprofen, but some other ones that are commonly used, and of course some that have antihistamine products as well, so topical antihistamines too, that's important. Okay, what about other photoallergens? Well, you can have occupational photoallergic reactions in an occupational setting, and I've seen some people working in a factory producing veterinary non-steroidals for dogs and cats, and he got an airborne, a photoallergy to carprofen used with that. Many of these things are outdoor allergens. It really makes sense, doesn't it, that you're going to put these things on, and the ones that cause a problem outdoors are going to cause a problem. So it's kind of logical. Don't forget the plant extracts as well. Not only phototoxic reactions, you can get photoallergic reactions. And in India, for instance, if any of you ever go and work there, the top allergen is Parthenium, which is a plant that only grows in the Indian subcontinent. We'd never see it here. I have seen people with Parthenium dermatitis, but they've got it, and it became chronic when they were in India. And don't forget the fragrances. So I've published on this, and particularly the cinnamates, but there can be other fragrances which become photoactive. It's very important to test to their own products, again, because of compound allergy, or perhaps for new or emerging allergens that we don't think about. And sometimes there are unexpected sources of these photoallergens, as I said. I think the unit at Antwerp are very helpful for lending allergen specimens if you don't have them to test in your own unit. So Professor Arts at Antwerp and Ella Dendoven have been extremely helpful for that. So this is a recent case, just to have a think about this. So patient developed this acute rash whilst visiting Sharm el-Sheikh in Egypt. And this was in the acute phase. It had all, when I saw the patient, it had all sort of resolved a bit, and there was just post-inflammatory hyperpigmentation. It was very itchy at the time. So it clearly, I think anybody, even a non-dermatologist, would realize this is something exogenous. It's coming externally. This is a pattern that's really bizarre. We do sometimes see that sort of thing in dermatology, like erythema gyratum repens, which looks really bizarre. But this is something clearly. Can any of you guess what the exposure was here? Well, I'll give you a clue. So she had a book resting on her abdomen, and this, you can see NYPD red in reverse, mirror image on her abdomen. It's the most amazing thing. I mean, it's just astounding. So I presume this is probably a benzophenone containing ink. It may be something that's reacted with the sunscreen she was wearing, and of course she was sweating and it was hot and so forth. So it's probably a photoallergy, but we're awaiting testing. But it's a really amazing case. Okay, in the final few minutes, I would like to talk to you about photopatch testing in photodermatology and how to do it well. Let's start at the very beginning. So it relies on the fact you have taken a good history, so you're selecting your patients carefully, and you're selecting the right allergens that are appropriate for the patient. You need to have reliable patient skin. If they've got really bad atopic dermatitis all over the place, it's very difficult to do the testing. You need to have good patch test technique, and you need to have a regularly verified UVA source to do this. So let's carry on. Reliable patient skin, what does that mean? Well, it's normally got to be clinically normal for about 2 weeks. This is also kind of the same advice for ordinary patch testing, of course. No excessive sun exposure for about a month. If they're very heavily tanned, clearly all the immune cells are going to be out of there. That's why we use the treatment for phototherapy. So as using it as a biological test system, the back of the skin of the back, we don't want them to have a very heavy tan. That's going to cause lots of maybe false negative reactions. They should not be on systemic immunosuppressives if possible, but you can do it if you have to. And dupilumab and other things, you can certainly test on that. No topical steroids to the back prior to the test, maybe 2 weeks. It depends on the potency, but certainly I wouldn't want them to have potent steroids within a few weeks on the back. Otherwise, these are validated, predictable tests using chemicals with known concentrations and so forth. And there's Anton de Groot's book, which is free to anybody who's a member of the European Society of Contact Dermatitis. And I would recommend anybody who's interested in allergology should become a member. Reduced fee for students or for trainees. The testing takes 5 to 7 days to perform, and the subjects have to keep their back dry, like ordinary patch testing. So we put all the chemicals in and use a micropipette for liquids, and we're putting them on the back, and then you mark the back, just as for ordinary patch testing. There are obviously ESCD guidelines for good patch test technique if anybody wants to look at those. And there are also recommendations about grading the testing, so doubtful reaction, weak positive, strong positive, and a bullous reaction. And these are the same as for ordinary patch testing. And you all have been exposed to this or will be at some point in your training. Of course, you can have a negative reaction or an irritant reaction as well. And these are just some clinical photos of the reactions that you might see. Okay. But what's the difference with photopatch testing? Well, you put the things that you want to do the test on, you have to put a duplicate set of tests. And so you put, let's imagine you're doing the European photopatch baseline series there, and you do it twice. Or you may be doing the fragrances. And of course, you're doing the patient's own products twice. Because what you're going to do then is you're going to irradiate one of those groups of tests with UVA, and you're not going to irradiate the other one so that you can see if there's any difference with ultraviolet exposure. So 48 hours, the patches are removed, you irradiate the side that you want to do, and the other side is shielded. It's very important that they're adequately shielded during that process, or else you're going to contaminate things. And then you do a reading 48 hours later, and sometimes you do an even later reaction if necessary. The UVA source, well, there are various different ones, but you can use a Philips fluorescent tube. But don't forget that over the lifetime of the tube, there's going to be some variability, and they need to be checked to make sure they're emitting the right amount of UVA. So you need to do that very carefully. And usually it's a medical physics department to do that. Typically, without a history of marked photosensitivity, we are going to use 5 joules per centimetre squared. But you can use lower amounts of UVA if they have a history of photosensitivity. And of course, ideally, you want to do some skin photo tests before, really, ideally. Certainly, maybe you want to think about doing an ANA as a screen. But if they are known to have photosensitivity then to UVA, then they're going to come up, the whole patch test thing will come up, and you won't be able to see anything. And sometimes this kind of you don't want to do it like this, but you can make the diagnosis of some form of lupus or whatever else, just by this, because they have a really unexpectedly strong reaction to the UVA. If they're very sensitive, you just can't do the testing, and you have to use your clinical abilities. And you maybe want to send to Leuven or somewhere else who are going to do the testing. And the history is mandatory before you do this, like it is for phototherapy. Very important to do the history before you do the testing. The first principle of medicine is to do no harm. Okay, so what sort of outcomes can we get? Well, there are lots of things. You can get photoallergy, you can get phototoxic, you can get an irritant response, you can get a photo-augmented irritant, you can get a photo-suppressed irritant, you can get an allergic one, you can get a photo-augmented allergic, you can get a photo-suppressed allergic, negative. So you can get a lot of things, but this is a bit too much detail, really. So we're going to look at this in the scenarios here now. So let's imagine we have somebody, we've tested for octocrylene and maybe many other things. We do a reading at day 2, and the octocrylene response is negative, and at day 4, the octocrylene on its own is negative, but the octocrylene, where it has been irradiated with UVA, is positive, 1+ reaction. So what's the interpretation? This is easy. It's a photoallergic contact dermatitis to octocrylene. So then you need to establish relevance. You need to look at their products, if you haven't already, and see what is in it, and look at their cosmetic items, otherwise shampoos, foundation, other things that may contain topical sunscreens. So that's an easy one. Now we're going to have something else. So we have octocrylene, which is positive on day 2, and also on day 4 with 1+ reactions. And in the UVA exposed test, we're also seeing a 1+ reaction at day 4. So what is the interpretation here? I'm sure everybody knows the answer. That's why it's just so easy, you just don't want to even bother saying it. So it's just an ordinary allergic contact dermatitis to octocrylene. So don't forget, you can just get an ordinary, it doesn't have to be the fancy photo test. Just because we're doing the test, it's always nice. Ooh, this is exciting. Aren't I clever? And I thought about that, and that's great. But it can just be an ordinary allergic contact dermatitis to octocrylene. Okay, be careful, because this can be complicated because of these photo-aggravated or photo-inhibited reactions just with ordinary testing. That's the first thing. The second thing is not all positive reactions are going to be relevant, and that goes for ordinary patch testing as well. You may need to confirm the relevance with a repeated open application test. Be careful, because actually some of these sunscreen ingredients are rather irritating on the skin, and when people are already atopic or have a sensitive skin type, they may give you a false positive, and you need to be very careful to look at the difference between the day 2 and the day 4 or 5 reading for that. And be careful, there are studies done, they call them north, south, east, west reactions, where actually when you test the same thing 4 times on a back, you may get slightly different results, because the top of the back is the most sensitive for picking up allergic reactions on patch testing, and other bits are less good. The arms, the legs, the tummy are also less good. So you don't get 100% concordance even testing with the same thing. So sometimes you need to retest. Be persistent. Sometimes that sunscreen may be in an unexpected place, like a shampoo. Okay, so I'm finishing now. We're going to talk about the learning points. Careful history and examination, outdoor allergens, gardening, sunscreen use. Look at the skin creases. That might give you a clue whether it's phototoxic or photoallergic. In real life, it can be difficult sometimes. Do not forget the topical agents. The patient may not mention them spontaneously. Don't forget neglected and forgotten medications like herbal or food supplements. They can be causes. And the photo test, well, may guide UVA dose in photo patch test, and you need to take advice before you start doing the photo patch test if you're not sure about that patient. Otherwise, the gold standard investigation is the photo patch test, which is very simple, and most units should be able to provide that. Don't forget to test for the patient's own products. And of course, photoallergen series need to be regularly changed and modified depending on trends in cosmetic ingredients. So things come out, new things come in, and so forth. Be persistent. Sometimes the relevance is difficult to find. Sometimes your testing may not be relevant, so you need to let the patient know that it may not be the cause of the problems. I am open for if we have any time for questions, but you can always email me if you're shy. And also anybody interested in global health or WHO related stuff, then you can always contact me on my email here. Thanks very much.
Thank you. Thank you for this excellent talk. Is there any question? Immediate question.
Oh, yeah. My God. Oh no, this is worrying because it's Professor Lambert.
Thank you for a very clear presentation, but I have one question. You didn't mention any medication as photoallergic.
Oh, well, yes, of course, yeah, absolutely, yeah.
So, and it's also the spectrum than UVA?
Yeah, although I think the literature shows there's many different ones.
It's more difficult, it's the most difficult.
Exactly, and I think we're all getting more interested in visible light as well as cause for all of these sort of things. So I think watch this space, but yeah, it has broadened out a lot more now. Yeah, absolutely.
Because it's the most difficult part of the story.
Thank goodness I could answer the question.
Thank you. Any other question or remark?
Thank you very much. Is curcuma also something that we need to ask for?
Curcuma, yeah, absolutely, yes, one of these other plant-derived things that could be important, and it's amazing, people just do all sorts of weird things. They're making pastes of plants, putting it on their skin, and, all sorts of things. I mean, these influencers on TikTok and everything, you just... onion skins going everywhere, that can cure everything. So I think you need to take a very detailed history, and they might be shy of telling you, and you may need to specifically to ask them, well, what have you put on the skin? And certainly when it looks quite exogenous, you need to be very careful with your history. But you're absolutely right, yeah.
Also when they take it orally.
Orally as well as topically, absolutely, yeah.